All right, good morning, good afternoon, wherever you are. I'm Ariana Longley, the Chief Operating Officer here at the Patient Safety Movement Foundation, and I'm excited to be presenting in this webinar to congressional staff who the patient safety movement is and what we do. Just a few housekeeping items for the live webinar. If you have any questions, you can pop them into the chat or the Q&A session and section. And at the end, I will address those. To keep a clean recording, I won't click around and touch those during the program, but don't worry, I will answer your questions at the end. And also this recording will be posted online afterwards. So if you want to share it with a fellow staff member or someone else, please feel free to do so. So with further ado, I'm happy to get started. So let's start with the problem. So the problem that we're talking about today here at the Patient Safety Movement Foundation is that hundreds of thousands of people die and millions are harmed every year due to prevent world, but it really does affect millions of people as far as death goes every single year across the world. So these are two studies that are pretty famous that we use a lot here in the patient safety world. One is from Marty McCary, who is based out of Johns Hopkins University. It came out in 2016, and his estimate was that around 251,000 Americans were dying preventably in hospitals every single year. And then the study to the right from John James, he lost his son due to a medical error, and his estimate said that it might be more like 440,000 Americans dying every single year. John James testified in 2012 in front of Congress to talk about this issue. And this is a significant issue, especially during COVID, and we'll talk about that in a few minutes. So first, I want to talk about what are medical errors. It's something that we don't talk about a lot. So a medical error is an unintentional, preventable adverse event. And this is important. It's whether or not it's evident or harmful to the patient, but it's something that shouldn't have happened and it leads to unsafe care. Medical errors are most often made by health workers who mean well, but operate in a healthcare system lacking systems and processes that are highly reliable. Examples would include aviation, power, and oil. We know that those are really highly reliable industries that really focus on preventing errors from happening. They can be catastrophic, but I really want to hone in on the fact that we're all for supporting health workers. We believe that they're operating in health systems that are not designed well. And we know that they go to work every day trying to heal and help people. And sometimes things go awry and they should not be blamed for that. So I'm going to give you a few examples of medical errors. So example number one, your son tests positive for COVID-19 and is admitted to the hospital. Due to a lack of masks, your son's caregiver is not able to stop the spread of infection and is also infected. This is preventable. Two, your grandmother goes into the hospital for a hip replacement and gets an infection at the site of her surgery and dies 5 days later. This is preventable. This is really common. People always talk about how, so-and-so gets infection after surgery. And this used to be thought as just the cost of doing business, the cost of opening up a human body. And that is no longer the case. Infections are preventable when they're happening in the hospital. Number three, your neighbor has an asthma attack during allergy season and goes to the emergency department for relief. The medication they give your neighbor is 10 times stronger than it should be, and he dies. This is preventable. Medication errors are quite common and quite deadly if they are not caught. And number four is your brother is in a skateboarding accident. He hits his head and becomes unconscious. In the hospital, they put a tube in his trachea and it becomes dislodged and he dies. This is preventable. That's an issue that we call unplanned extubation, where the tube is not secured properly and can be dislodged. So these are just a few examples. The patient safety movement has developed over 50 solutions to try to prevent these adverse events from happening, and we'll talk about that in a few minutes. So I hope that's helpful in kind of guiding you around what we're talking about today. Now, COVID, we're not out of trouble. It's currently April 20th, 2022, if anyone's watching this recording later. And I wanted to highlight a really excellent New England Journal of Medicine article that came out a few months ago in February. And it really highlights something quite alarming that I think you all sitting in our nation's capital or in our state capitals can really help address. And that is that COVID has worsened safety. And this may not be surprising, but we do have some data around it now. And the fact is that some of these patient safety concerns that we've been addressing for years and gotten really good at eliminating and ensuring, sustaining that reduction has almost totally reversed. So CLABSI, which is known as central line associated bloodstream infection, that's when they put a central line in to your heart, they deliver your medication directly to your heart, and that can become very fatal if it gets infected. You can see here that this is Lee Fleischer, the Chief Medical Officer of CMS, Michelle Schreiber from CMS, Denise Cardo, and Arjun Srinivasan, excuse me if I mispronounced that, from the CDC. They've all 8% in the second quarter of 2020. And this is also happening outside of hospitals. This is happening in skilled nursing facilities where they've seen falls increase by 17% and pressure ulcers increase by 41%. So I say this just because this is a really big issue that as we come out of the pandemic, we're going to have to make up for lost time because this is affecting humans. This is affecting people who are getting infected and sometimes being harmed and sometimes losing their lives. So the other thing I wanted to focus on is this problem around unsafe care. The public does not understand this. And I say that because we did a poll with the American general public 2 years ago, and then this year we repeated with the American general public and a few other countries. The gist is that when we ask them, have you heard anything about medical error or patient injuries in your local community in the last year? 87.3% said that they had heard very little or nothing. And that's concerning. If we're talking about somewhere between 251 and 440,000 people dying due to preventable meaningful way, not to scare people and have them not seek care. That is definitely not what we're definitely not trying to do that, but we need to educate them and help them understand that this is an issue and there are ways that they can get involved and be partners in their healthcare. So this was kind of the key takeaway from our poll from 2020 and 2021. So just to give you a bit more I guess, history on patient safety, if you're interested. The first report came out in 1999, and that first report that came out from the Institute of Medicine, now the National Academy of Medicine, estimated that 44 to 98,000 patients die each year in US hospitals from preventable medical errors. And it was focused on errors of commission. In 2004, just 5 years later, there was another report that came out called Achieving a New Standard for Care, also by the Institute of Medicine. And they focused on errors of omission, they focused on communication problems, and that the context is just as deadly when we're talking about medical errors. And so these are two really seminal well studied. So we have limited examples that we can share, which is unfortunate for such a big issue, but there are a few that you can see here that I've noted. And it's estimated that it can cost anywhere from 9 billion to 958 billion. So quite a wide range, but we're in the B's. It's a lot of money. And this is just in the US. Adjusting for inflation, that 958 billion that's mentioned in the Goodman article in Health Affairs, which is this article here, it could now be upwards of $1.44 trillion. It's a lot of money. Globally, just for your reference, it's estimated that 15% of hospital expenditures and activity in OECD countries can be attributed to treating safety failures. And that's a lot. That's a lot of waste that can be avoided if we focus on systems. So a bit about us, the patient safety movement. We have a very bold vision, and our vision is to achieve zero preventable patient harm and death across the globe by 2030. And this is, you may say, these people are crazy, you know, getting to zero, that's impossible. It may be impossible, but it's the right goal to focus on. We look at these errors and these issues, and they're affecting families, they're affecting individuals, they're affecting people like, you know, people like us, our moms and dads, our sisters and brothers. And so it's really the only acceptable goal to shoot for the stars and focus on zero. And so our mission, aligned with the vision, is to urgently unify people and collectively improve patient safety across the globe. We want to work with as many people as possible to eliminate preventable medical error. All right, so our 3 core competencies. First is we forge global relationships, partnerships, and collaboratives to actively promote change for patient safety. So working with as many people as we can. Number 2 is developing and disseminating patient safety education to governing bodies, health professionals, students, patients, families, and the public, pretty much everyone. We want to try to educate as many people as humanly possible. And third is we create public demand for safe and highly reliable care. And this is where you guys really fit in, on the legislative side of things, is how can you help create demand by making this something that is required for hospitals and healthcare organizations to do. So when we talk about forging the global relationships, we really, as I mentioned before, we can't do this alone. Everyone has to be put together. And what we believe that we're doing uniquely outside of other patient safety organizations who are oftentimes our partners and really important is we're trying to get all the different types of professionals, respiratory therapists and nurses and doctors, the lawyers and the liability insurers, the healthcare technology companies with the engineers. We want them all to be talking about how we can improve patient safety. And we can't just focus on one side of the equation. We have to include patients and families as well. So these are just a few examples of the groups from the advocacy and awareness groups, the clinical science and technology groups, finance and policy, and then my academia squared disappeared, but all different groups. They all have some part to play in improving patient safety. So with that said, oh, there it is. With that said, we have partners all over the world, over 35 countries, 450,000 people have committed to zero, our very bold mission of zero. And about 275 organizations from hospitals and healthcare organizations have participated. And that now results in 4,800 hospitals and healthcare organizations represented across the world. Now, for the purposes of speaking to you all here in the US, I have taken a snapshot of what it looks like here in the United States, who we're partnering with. We do have this interactive map on our website. The different colors indicate different types of groups that we work with, but we're really trying to hit all 50 states and get people involved to improve patient safety. All right, so moving on to kind of item number 2 from those core competencies that we focus on is developing and disseminating the patient safety education. An interesting fact that you might have heard before, a scholarly health-related article patient safety solutions. And these are our evidence-based best practice summaries that we revise annually with groups of multidisciplinary experts from across the world, including patients and families, to address the most common patient safety issues. To date, in April of 2022, we've created almost 50 of those. And we include things like clinical blueprints and maps, ways of virtually coaching people so that they can implement these best practices in their institutions. And we really want to generate awareness among the general public and provide them with education about how they can keep themselves safe through webinars and events like today. So these evidence-based best practices, the apps, this is just an example. So you can see the kind of grid on the left. This is an example of some of the apps that we have. In the middle, we have a how-to guide. It explains the evidence-based best practice summary, the executive summary for executives, a leadership checklist, how they can understand, the leaders can understand common patient safety problems and the implications, the clinical workflow, how they can develop specific education for patients and family members around a specific issue, performance improvement plan, and then just additional information about what we know about this patient safety issue. So it's really actionable. We're trying to get people to, based on the checklist on the right, upon admission, ensure that they're doing everything possible to reduce catheter-associated urinary tract infections. And for routine care, what are the things that they're going to have to do? And oftentimes what's super interesting is when we've gone out and presented to hospital leaders will say, oh yeah, we're doing everything on the, we're doing everything. We know what we're supposed to be doing. It's harder to do than you think. And when we present the checklist to them, they can't check off all the boxes. Sometimes they can only check like 9 out of 10 or 13 out of 15. And so they become very helpful. They say, wow, I didn't know that part. Was this new? We don't do this in our facility. And it can be really facility to ensure that they're doing everything possible, because if they're not doing everything, then it's going to be really hard to get to zero. All right, and number 3 is creating public demand for safe and highly reliable healthcare. We believe that every single healthcare organization should become highly reliable. It hasn't been optional in nuclear power, aviation, oil and gas. And we've seen examples, I'm located here off the coast of California where we've had oil spills. We see the Boeing, 737 MAX kind of things. Sure, there are scandals that go on, but most of the time, these industries are highly reliable and can be held accountable for mistakes that happen. And what's also interesting is that these industries also anticipate errors before they occur and design safe systems to prevent them. So in healthcare, we've been pretty reactive. We see things happen and we say, okay, we're going to now make sure that doesn't happen again. But there are ways of using the near misses, we call them, things that could have resulted really badly, but didn't, and study those and ensure that we learn from how we patients and health workers who are caring for our patients to create a more highly reliable healthcare system. 2 is we provide training on performance improvement and leadership development, as well as coaching teams through improvement projects. So we have this service that we can provide, and it can be really helpful for hospitals who say, okay, now I know what I need to do, but I need help with the implementation of it. We need help. So we provide that support. 3 is it requires a significant culture shift and the dedication of senior leadership. And this can be one of the most challenging pieces, right? Is you can have well-intentioned nurses and respiratory therapists and doctors at the front line who want to do the right thing. But if the senior leadership, the board of directors, does not value safety and high reliability and want to create a highly reliable system, it can be really, really difficult. And so we really want to empower leaders in our healthcare system to focus on that culture shift where they can report when something goes wrong without fear of being reprimanded. And that if we look at aviation, if the co-pilot sees something that the pilot might be about to do, in aviation, they can report that and will never be prosecuted for that. It's all, the opportunity of shared learning and improvement that that mistakes are really rewarded, and reporting of mistakes or reporting of near misses is rewarded and encouraged. In healthcare, that is not the case most of the time in most of our organizations, and we want to change that. And we create public demand here at the Patient Safety Movement through two main events each year. We do have sometimes other one-off events, but World Patient Safety Day, which was adopted by essentially everyone needs to know about patient safety, and this is a great day to focus on it. And then our World Patient Safety Science and Technology Summit is coming up here at the end of the month, and it'll be April 29th and 30th of 2022. We bring together leaders from government, from CMS and CDC, from the World Health Organization, from independent hospitals and health systems, as well as patients and family members and other types of experts within the scientific community to talk about what's the latest, what do we need to focus on here in the patient safety world. All right, so the root causes of error. Let's move into these. So we have what we've called a patient safety moonshot that we launched in early 2021, right around the inauguration. And we felt like it was a really good time to focus on these kind of bigger issues that surround patient safety, that honestly, no matter whether you're in the United States or you're in Nigeria, these issues underpin everything in a health system. And so we thought, years ago, it was thought to be, really, really hard. It was going to be nearly impossible to get to the moon, and we did it. We thought it was going to be really difficult to get rid of polio. We're almost there. There's all of these moonshots that have been established over the years, and we wanted to focus on a patient safety moonshot. I may have mentioned that, we have our goal of 0 preventable deaths by 2030. We originally had a goal of getting there by 2020, and we missed that goal. But what's really encouraging is when we talk to people in our board and our network, they said, yes, you missed it, but we respect you for trying. And we think that it's important to set another law. Bit more slides. Okay, so the lack of safety data. So, I presented to you several studies, the 251,000 people dying in America due to preventable medical errors, up to 440,000. The data that we have are only estimates, and that's because we don't have any requirement to report all medical errors to a specific entity, or to have even like medical error listed as a primary or secondary cause of death on death certificates. And so it can be really difficult to come to people like you in Congress and say, we need to do something about it. Here's the data that we have. We have these data sources. We only have estimates, and it's the best that we can get, but we need to do better. And so we'll talk about, the third, the accountability and oversight helps to address this. But we really have a lack of safety transparency related to data. And one of the underlying issues is that organizations and clinicians are often really fearful to be open and honest about errors, and are fearful of reporting them because they are blamed and shamed, and they fear reputation damage or potentially, getting into litigation. There's the Redonda Vaughn case coming out of Vanderbilt that is active right now, and we can see why people are fearful. People are getting, nurses like Redonda are getting convicted of horrible, heinous crimes that are only due to the fact that their health systems were not set up with a steady and highly reliable health system. So we really need to focus on preventing system failures instead of blaming individuals. Second is misaligned incentives. So we believe that there really is a significant misalignment of financial incentives between healthcare organizations do to prevent these medical errors, really, instead of focusing on what happens after someone is diagnosed. Organizations are also rewarded by the number of procedures that they complete and the number of patients that they're cared for, than more than they are patient safety and quality outcomes. And I know with value-based care, quality is on the forefront. There isn't a lot in there around patient safety, things that we can look at, measures to look specifically at patient safety. So I think we can do more there. And we need to align financial incentives within the needs of the patients, which ultimately means we need to make it easy for organizations and clinicians to do the right thing, to make the reports and do the right thing. And lastly, I alluded to this a bit, but the lack of region appropriate regulatory oversight is concerning. In aviation, when there is an event that occurs, the NTSB, or the National Transportation Safety Board, investigates the root causes and shares that information across the industry, saying this plane crashed because of XYZ. We want you all to know that, so this doesn't get repeated. If there's a problem with a certain type of, if there's a mechanical failure, there's learning, and people pay attention to these reports. They want to make sure that their plane doesn't go down. In healthcare, we don't have anything like this. And we believe that there's a need for, call it a national patient safety board, this type of oversight within organizations in healthcare to be more transparent with their safety data. We need to better investigate the root causes of harm, not only nationally, but on regional levels, to focus on the preventing of errors before they occur. And so this is why we're presenting to you today. We need to get policymakers involved and create global and regional partnerships for sharing data. So with that said, what can you do? You can watch and share over 104 patient stories. We have mapped out, I think it's now 28 states worth of patient stories on our website. Many of them are written, and a few handful, maybe a dozen or two, are also video recordings. And they're really inspirational. They can really show you that this is happening to individuals and really tragically affecting family members who oftentimes can't get answers due to the lack of transparency. The other thing that you can do is you can follow our progress and sign up for emails. Make sure to keep updated on what we're doing and participate in any events to keep a pulse on this issue. If this is an issue that you think that whoever you work for would be interested in helping to support, and help us find a way to drive change through legislative and regulatory processes. You may have ideas that we haven't gotten through yet and thought of. We'd love to partner with you and be a thought partner on how we can drive change to improve patient safety. And please invite us to speak with the elected that you work for, or if you're not the health staffer, who can we speak to get more into the weeds and talk about what we can do in your state or federally. So with that said, I'm now done with my presentation. So I'd love to open it up for Q&A. So I'll take a look and see if there's anything. Okay, I don't see anything in the Q&A or the chat. So I really appreciate your time. Thank you so much. And I hope you contact us and we can work with you to improve patient safety together. Thank you.